So let's get started. So I'd like to say a big thank you to our two presenters today. We have Alana St. John and Simon Potts joining us. Alana is the nurse consultant for Central Vascular Access at Flinders Medical Centre in Adelaide. She provides clinical expertise across the continuum of care and is responsible for the planning, provision, standards and management of central venous catheters at Flinders Medical Centre. And Simon is the Senior Intensive Care Pharmacist for Flinders Medical Centre, so in Adelaide. Thank you, Simon and Alana, for taking time out of your busy day to give us this webinar today. I'll hand over to you.
Thank you. So my name's Alana and I am the Nurse Consultant for Central Vascular Access at Flinders. First, I'd just like to say thank you to SHPA for the opportunity to talk with you all today. Open disclosure, I'm not a pharmacist, I am a nurse, but I hope that you'll learn something very valuable from today's session. Oh, just give me 1 second. It's just some bits for you to read later. There we go. So the overview of our session today is I'm going to go through some considerations with vascular access, and then we're going to look at different types of vascular access that are often used in the ICU. There are some catheters that aren't here, but I wanted to make it as general as possible for people who work outside of the ICU as well. So what I particularly like about vascular access and why I think that as pharmacists it's good that you have an understanding of vascular access is that IVs are the most common invasive medical device, and approximately 70% of inpatients will receive a peripheral cannula, 29% of general patients will receive a CVC, and about 80% of our ICU patients will receive a CVC. IV access is used in all patients, whether they're acute to chronic and across their lifespan, and all specialties. So everyone has something to gain from learning about vascular access. The last reason why I think it's important that pharmacists have an understanding about vascular access devices is because you will be asked questions about them, whether it's to do with administration, compatibility, etc., etc. So there are a lot of considerations that need to go into reasons why we would insert a line in people, what line we would insert, and some considerations that we need to give before we're accessing a line. So you can see there's quite a list here. All vascular access catheters are not created equal. They have many different features and we would use them for different reasons. When deciding to insert a catheter or to access them, we need to consider the anticipated duration of the therapy, the urgency for the access, the type and number of infusates that we might need, the pH of the infusate, osmolarity of the infusate, if they're a known irritant or vesicant, the type and location of the device, the rate of infusion, catheter size, condition of the patient's veins, and patient preference. So as you can see, there are many considerations that come into play. We're not going to go through all of them today, but I thought we'll have a quick look at a couple of the considerations, those being pH and location of a device. So we're going to talk a little bit more later when we're looking at the different lines as to what they can be used for, and one consideration is what would be prescribed and the pH of that. So you can see that there is a table here looking at the pH of various household solutions and known solutions. And you can see that there's quite a variance in pH. A lot of these are our IV antibiotics. So you can see vancomycin will range from 2.5 to 4.5. Now our green zone or our happy zone for peripheral cannula access is from 5 to 9. So anything that sits out of this has historically been things that would have to go through a central line. However, we can't always rely on just the pH alone. In fact, all of those considerations that I spoke about earlier need to be factored in, and erythromycin is an example of that. So the pH of erythromycin is between 6.5 and 7.5, but erythromycin is actually known to cause severe tissue damage and necrosis if put through peripheral lines, and so we would only use them through a central line. Another interesting and topical point is you'll see that with a pH of 13 is bleach and oven cleaner. So contrary to recent suggestion that injections of disinfectant may be a viable treatment for COVID-19, I would strongly advise against it, especially via a peripheral route. So another consideration is looking at where we're placing vascular access devices, and this one's quite important because it takes into consideration the diameter of the vessel and the flow rate of the vessel. So infusate will exit from the tip of the catheter into the bloodstream. Therefore, the diameter of the vessel and the average flow rate are an important consideration, as it provides an indication on how quickly the infusate will be diluted. So imagine if you look at this table, a peripheral cannula is put into the back of a patient's hand, say in a metacarpal vein, where an average diameter is just 2.5 millimetres and has an average flow rate of 10 mils per minute. An 18 gauge cannula, that's the green one there, so they're a very popular size for insertion. So if an 18 gauge was inserted, which has a diameter of 1.3 millimetres, the cannula will now occupy over 50% of the vessel. And with this comes reduced blood flow, which is now closer to 5 mils per minute. So with this in mind, consideration needs to be given to the pH, osmolarity and viscosity and rate of infusion of any infusate that would be administered through this line. The same goes when you would look at PICC lines that are put in the upper arm, say the basilic upper vein, so they're 8 millimetres. If we put a PICC line in that patient, that will be reduced by at least 2 millimetres, depending on the size and lumens, and therefore increases the risk of complications to the patient. So now we're going to look at different types of vascular access, and first we're going to start with a really common one, which, as I mentioned, 70% of our patients in hospital will receive, and that's called a peripheral intravenous catheter, or a PIVC, or a cannula, or a drip, or a line. Lots of people call them different things. So what is a peripheral cannula? Well, it's a small, about 3 to 4 centimetres, flexible tube. It's inserted through the skin into a peripheral vein. Ideally, that would be in the forearm. However, in practice, they're often inserted into the back of the hand, as you can see in the picture, or into the cubital fossa. We generally don't like them to be inserted in these places because they're areas of flexion, and so with the movement of the wrist or the elbow increases the risk of complications for the patient. These peripheral cannulas are inserted by registered nurses and or medical officers. They always have a single lumen, so there's only one lumen. It doesn't matter what's connected to the rest of the line, it all will meet at one point. And we'll go into that more later in the presentation. So what would we use a peripheral cannula for? Why would we insert them? So through a peripheral cannula we can administer medication and fluids that are suitable for smaller vessels with smaller blood volume and a slower flow. So we would still give consideration to the pH and osmolarity and all the things we spoke about before. Things that absolutely cannot go through a peripheral cannula include parenteral nutrition, vascular active infusions, things like potassium, vancomycin, and many of the chemotherapeutic agents. These cannulas, it's a bit debatable in terms of how long you can leave them in for, but generally the recommended dwell time is between 72 and 96 hours, and routine replacement of them is generally not recommended. The next catheter that we're going to look at is called a midline catheter. So a midline catheter is a bit like a line between a peripheral cannula that we just saw and a PICC, which is what we're going to look at next. So a midline catheter is a flexible and durable catheter. It's inserted through the skin into a large vessel in the upper arm, and the tip terminates near the axilla, so you can see on the slide here, as opposed to a peripheral cannula which would finish about here, and a PICC line which comes all the way through to the bottom of the SVC. So because midlines don't enter the central system, they are not considered a central line. Midlines are cut to size for the patient, so they will vary in length, but they're around 10 to 20 centimetres. Midlines are inserted using ultrasound under sterile conditions, and they're inserted by nurse consultants or practitioners in medical imaging departments, and some hospitals even offer bedside insertion. So as I said, they're inserted in the upper arm, so in the basilic, brachial or cephalic vessels, and we would insert a midline in patients that we can't get a central line in, and we need to get access, but not necessarily for infusions that have to be delivered centrally. A common thing is for administration of antibiotics for patients, because these midlines can stay in for around 3 to 4 weeks, and we can give antibiotics during this time without the need to put a PICC line in them, which comes with its own risks. There are some people who can't tolerate the insertion of, say, a PICC line because they can't lie down flat and tolerate the procedure, and so midlines are a really good option. It's also a good option for patients that would have otherwise required multiple peripheral cannulas. It means that with one insertion we can complete their therapy. Some interesting things about midlines is that they're generally now pressure injectable, so they can have CT contrast administered through them. They can also be used for blood sampling, so they're really useful catheters to have. To tell the difference between a midline and a PICC line can be a little bit challenging, but most of the midlines now have midline written on them, either on this part here near the needleless connector or the bung, or just near the insertion site, so look out for that. So the next catheter we're going to is a central venous catheter. So these are really useful catheters. We use large numbers of them in intensive cares and in operating theatres. Central lines are multi-lumen. So that means that you have several different tubes, if you like, that can be within the one central line. So if you look at this picture down the bottom, you'll see that this is a triple lumen catheter, and all of these 3 lumens run through the catheter, and they actually exit at different points along the catheter. So one's about 5 centimetres back, another one is 2.5 centimetres back, and then one at the tip. So central lines come in various different sizes, so you can get single lumen and double lumens for paediatrics, you get triple lumens, quad and quints lumens. Generally we will use triple lumens in our unit. Every time that we increase the size, so adding additional lumens, we increase the risk of infection and complications, so we want to keep them to a minimum where possible. So this is the first line that we're looking at that's actually a true central line. So you can see that it enters the skin just about here, and then it goes through. This is a subclavian insertion, so it's going through the subclavian vessel and then down to the bottom of the SVC, or the top of the right atrium, which is ideally where we want catheters to finish. There are 3 places that we will insert central lines. It's either the internal jugular up here in the neck, the subclavian vessels, or the femoral vessels down in the groin. They are inserted by medical officers, though in some states and hospitals they are inserted by nurse consultants or nurse practitioners. It's done under sterile conditions, and they're generally inserted within ICUs, EDs and operating theatres. So CVCs, because they're tip terminating in the bottom of the SVC or the top of the right atrium, they have really large volumes of blood going through there, and really we could administer anything that we need to. So they're ideally used for central pressure monitoring, which is something we would do in the ICU, for the administration of parenteral nutrition, chemotherapy, long-term IV antibiotics, though this isn't a long-term line, vasoactive drugs, fluid resuscitation. Because there's multiple lumens, we can administer multiple things at the same time because they're in their separate little lines. Just imagine them like railway tracks, so all of the lumens will run parallel to each other, but at no point do they cross over or mix. There are several different types of central lines, so have a look in your organisation to see what type you use. So very briefly, the picture of the central line here, so we use arrow central lines, and this one is just a standard CVC, so it doesn't have any coating on them, so no intraluminal, so inside the lumens, or extraluminal on the outside of the catheter. Doesn't have any coating to reduce infection or prevent complications. So that's a standard line. There's also antimicrobial lines. So the antimicrobial lines have extraluminal and or intraluminal coating. It's often with silver and or chlorhexidine. There's also antibacterial lines, which have the extraluminal and intraluminal coatings of antibiotics. We use the Cook catheter, and they are coated with minocycline and rifampin. So the dwell time, so how long you would leave these catheters in, will vary by institution and will also vary by what type of catheter you use there. Again, the routine replacement of central lines is not a recommended practice. So next we move up to our PICC line. So our PICC line is still a central catheter because, as you can see, the tip does terminate in the bottom of the SVC, top of the right atrium. But as opposed to being inserted centrally, they're inserted peripherally. So they'll be inserted in the arm down here. A PICC line is a long, thin, durable catheter. It's inserted for long-term use. They are inserted using a sterile technique by nurse consultants and nurse practitioners primarily nowadays, but also medical officers. And to insert them we use ultrasound and fluoroscopy and or ECG guidance. So we would use a PICC line, as it's a central line. We would use it for all the same things that we would use a standard central line for, but for longer periods of time. So if the person needed several weeks of IV antibiotics or ongoing chemotherapy treatment, a PICC line is a great option because they can stay in for 12 plus months. PICC lines are available in single lumens, double lumens, or you can see on this picture here that you can also get a triple lumen PICC line. PICC lines nowadays are generally pressure injectable, so they can also have CT contrast through them. And you can see in this picture here that there are several lumens that say no CT, and then another lumen that has, it's a bit difficult to see, but it says power inject, and it'll have the flow rate written on there. The next catheter that we're just going to run through is a port. So ports are really interesting catheters because they are surgically implanted and tunneled, and they're completely under the skin. So you can see on the right, this is how a port would look in a patient. So depending on the size of the patient, you may or may not see that they have a port, but you will always see this about an inch wide scar that's just at the top of the chest, mid-chest region. So implanted ports, as I said, they're inserted in theatres. It varies in different places as to who would do that, but they are always inserted in theatres or within medical imaging with some anaesthetic. To access the port, because it's completely underneath the skin, you need to use a special type of needle called a non-coring needle, and that's inserted through the skin. You can see on this diagram here. It's inserted through the skin into the silicon top of the port, which you can see this silicon here, and then the needle goes right through to the bottom, which is a metal, generally reservoir. So once that needle has been inserted, then a dressing goes over the top of that, and then that stays in place. In our organisation, we'll leave that in place for 7 days, and then we'll change the needle over again. So ports are actually a brilliant option for people that need ready central access, that are coming into hospital regularly and don't want the difficulties of having an external central line like a PICC line that needs to be dressed weekly, and they can't shower normally and go swimming and those sorts of things. So with a port, they're a great option for patients, because when there's no needle in there, they just look like a regular person and they don't have to abide by all of the limitations that come with having a PICC. So the catheter is implanted, as I said, but it's also tunneled. So if you have a look over here, you'll see that this is the port. The port will sit here within a little pocket that's been created within the subcutaneous tissue, and then tunnelled through the subcutaneous tissue, the catheter will travel about 5 to 10 centimetres before it enters the bloodstream. So because it's completely implanted and also tunnelled, it has the lowest risk of infection. Many ports nowadays are also pressure injectable, so they can be used for CT administration. An important consideration with ports is they're generally only single lumen. So as you can see, the needle will go through until the same reservoir. There are some double lumen ports, in which case they would have 2 different ports side by side, and then they'll have a catheter which is split. So if you're only seeing one like this, or you can only feel one, then they only have a single reservoir. You can use a port for everything that you would use a standard CVC for. So again, any of your chemotherapy, IV antibiotics, fluid resus, potassium, blood sampling, everything can be done through a port. And a great thing about them is they actually stay in for five years or more. They're a really great option for people that need long-term access. Now, the next 2 catheters we're going to have a little look at are haemodialysis catheters, so for people that are receiving renal dialysis. There's a long-term renal dialysis catheter and a short-term, like acute dialysis catheter. So the first one we're looking at is a tunnelled haemodialysis catheter, so it's the same as the port that we just looked at, in that you'll see it exit the skin. From here, if we have a look on this lady here, you can see this is where the catheter comes out, and this site up here where there's a little stitch, that's actually where the catheter entered the bloodstream. So you can see that again on here. And this tunnel through the subcutaneous tissue will all heal, and there's a little cuff on this catheter to prevent the migration of organisms through the tunnel. And then again, it reduces the risk of infection for the patient. So there's still a central line, they terminate in the same place. They're inserted in interventional radiology or in theatre. Takes about half an hour, and then the catheter's ready to use. So they're a long-term line. We might put them in for a few months while we're waiting to develop a patient's fistula, or they'll have a graft. Sometimes they're permanent lines if we've run out of access options. But generally we'll keep them in for shorter periods of time and establish more long-term access. These catheters are used only for haemodialysis, so we don't use them to access them or generally take blood from them outside of the dialysis units. Though in saying that, if there is an emergency or a MET situation, there's still central lines and they can be accessed for anything that's required in an emergency. So these ones, the permacaths, look quite different to our vascaths. So these are short-term haemodialysis catheters, that's their technical name, but they're often referred to as vascaths because that's one of the brand names that we used many years ago. So vascaths are for maybe if you need dialysis for a week while you're pending the insertion of a permacath. So we might, a week or two, use them in the ICU or in the dialysis unit. They're about 16 to 20 centimetres depending on what side they're put in. They look considerably different to a central line. They're much thicker, so you can see the lumens are much thicker. They're really rigid, So this patient's lying down, but if he was sitting up, you would see that this catheter will stick up into the air as opposed to drooping down. That's why it's often known as the snorkel. So they look very different to a standard CVC, and they have these different clasps on them. Vascaths are inserted, again, they can go in the internal jugular, in the subclavian, or in the femoral vessels, and medical officers insert them. Also some nurse practitioners do as well, using ultrasound, and then they check position with X-ray. They are used again for acute short-term dialysis treatment, and we generally will not access them, access the lumens, unless the only exception is if they have a triple lumen. So you can see on this picture here that this lumen, this little one, is actually a central line lumen. And so you can use this to take blood or to administer medications, bearing in mind that it's actually a really teeny tiny lumen, so it wouldn't be ideal to be using this sort of lumen for the administration of highly viscous solutions or red blood cells or things like that. Getting to the end there, so bear with me. A little talk now about add-on consumables. So when we say add-on consumables, what I'm referring to are these sorts of things up here. So this one up the top, we have B-brawn here, but there are many different types. This is a disco fix, or what we call a manifold, and this is a three-way tap. They have stopcocks on them, which are these blue little bits here which twist in all directions, and they will open and close access to the various exit points. Now, add-on consumables are used because we require additional access on the patient. So you can see in this second picture that if we add this manifold or disco fix onto the three-way CVC, we now have 5 access points. Thing to remember with these is that they will still all enter and mix together within the same lumen. So you can only use administer medications through these sorts of add-on consumables if they are compatible with one another. You can see on the end here, this is another type of add-on. It's an extension set, often known as a chook's foot, but you'll see that although it's got 3 separate lines, and sometimes these are quite long, they still only come to the same point. So all of the medications will mix together and therefore need to be compatible. At the bottom here, it's just showing a cross-section really of the different catheters. So this is your single lumen here. Your double lumen catheters are often split equally, and then once you get to a 3 lumen and above, the catheter lumens are split in many different ways depending on the brand. But if we look at the triple lumen, you can see that there's 1 lumen which takes up half the catheter, and then the 2 other lumens take up a quarter. So it's important to consider what sorts of infusions you would put through the different lumens, because although this looks really big on this screen, the size of a PICC line as an example would be about 2 millimeters. So using the 2 smaller lumens, you would really want to only put things through there that are not viscous, and ideally that would be going through a pump, and anything that you need to put at large volumes would go through the larger lumen. And this just gets more and more challenging the more lumens that you factor in. So that was just a quick look at different central lines that we have. I hope you found it beneficial. If you would like to learn any more, there are several places you can look. So there's the Infusion Nurses Society, which I know is nurses, but they have a lot of free resources. The Australian Vascular Access Society is a great resource. They receive a lot of funding and conduct a lot of research, and they make all of their publications free on their website, so worth checking out. And also EviQ, so for the people that are in haematology and oncology settings, EviQ is a really great resource to look up as well. Some references for my images. So that's me. Thank you very much. Thanks for listening, and I'll pass you over to Simon now.
Hi everyone. So today I'm going to talk about IV drug compatibility and try and provide some practical advice to sort of help guide you through it. The content I'm planning on covering is relatively specific to ICU patients, but it can be applied to a general ward setting. It's also specific to an adult ICU. I can't really comment upon paediatric or neonatal compatibility. All I know in that sort of area is that Bluey and Peppa Pig are pretty compatible with my kids, but cauliflower and peas aren't. A lot of the content I am going to provide is practical advice. It's by no means meant to be a definitive you can do this, you can't do that. As with many things in the care of an ICU patient, there needs to be a conscious and well thought out risk-benefit consideration, and clinical judgment must be applied. What I'm hoping today that I can do is provide you with some tools to help fine-tune that judgment if it's not an area you've got much experience in. So I guess the first thing to ask is why is it a problem? I mean, there's the injectable drug handbook, the nurses administer the medications. These patients have so many other complex, other things going on. The simple administration of a few things down a little plastic tube can't be that big of a problem. So this is the chart from a patient in our unit last week. He had a 3-lumen CVC and 11 infusions running, combined with 5 intermittent intravenous medications. So the simple maths from that suggests that the ideal scenario of individually running drugs by themselves simply isn't possible. Now this is an extreme example, but if we were to go out to our 32-bay unit today, we would find similar examples where there's lots of medications, lots of patients where we can't just run into medications individually. IV drug compatibility certainly isn't a sexy research field. For most people, it's an afterthought and not something that captures the imagination. This table here I took from a paper that was published earlier this year, and it gives you some scope of the problem. It was a systemic review of Y-site compatibility of common ICU drugs with an individual review of the quality of the analytical techniques used. None of the papers identified used analytical nor reporting techniques that met all the quality criteria, and only 50% of possible combinations of 2 drugs had compatibility data. When you look at all the blank spots of the table, that's the stuff where there's no compatibility data, and there's quite a lot there. Of the data that was available, only 6% of it was available in set specific conditions which weren't really applicable to a patient bedside. So the reality is that this robust systematic review could only identify data for just over 40 of some common ICU drug combinations, not all the combinations. And of that 40%, none of them actually met the threshold for ideal analytical techniques. This is another representation. So this is from a paper last year looking at combinations on 74 ICU medical prescriptions. So they went around the unit, collected 74 prescriptions, and that resulted in nearly 400 combinations of different intravenous medications, of which you can see there that nearly 63% had no data for compatibility, and 6.4% were defined as controversial, and 1.8 were defined as potentially compatible. So again, that's over 70% of the Y-site combinations with limited or controversial data. This is a photo from my unit taken about a year ago. So what happened here was a nurse called me over to review a patient who she'd received from theatre not long ago, who had about 10 different infusions running. So you can see in the manifold here, this fine white powder, and this was resulted from a ketamine and heparin infusion running together. The nurse thankfully had spotted the white powder and had stopped the infusion. And thankfully, no harm came to the patient, but it was interesting to note that the patient's significant increase in post-op pain improved following the rearrangement of the continuous infusions. So the white powder was in this manifold here, and it's hard to see, but it was actually tracing up here and down into this line as well. This is another example. So this was a simulation combining the 2 medications that I'll talk about in a second that I did in a syringe. But a few years ago, I was walking past a bay with one of the intensivists, and as we were walking past, the nurse said, "Simon, seeing as you're here, I'll just check. This patient has been getting a heap of phosphate. And just about half an hour ago, I hung some magnesium as well. He's only got limited access, but they're fine together, right?" As soon as the nurse said that, the consultant and myself sort of came running in because we both realised what was about to happen, and we turned the pump off, disconnected the syringe, but unfortunately we were a bit too late. The CVC was already blocked. So unfortunately that patient had to have that CVC removed and another CVC inserted, which is 2 invasive procedures that were unnecessary. So IV compatibility is a common and frequent complication in ICU patients, but by a simple review, it is an area that as clinical pharmacists we can make a meaningful impact in patient care, ensuring patients receive uninterrupted administration of their medications, as well as limiting the number of preventable invasive CVC insertions they have. So references, I guess that's the best spot for us to start. So references at your disposal will depend on what subscriptions your local healthcare or hospital might have. It's certainly worth working with your drug information service or your health network library to ensure that you have adequate references at your disposal, as well as the nursing staff having access to simple references such as the injectable drug handbook. This is particularly important if you're setting up a new ICU or preparing for a higher acuity of patients in a regional area or somewhere like that you might not be normally seeing. So these are the references that so we commonly use in South Australia. Other states or other sites in South Australia might have other resources, but I'm not familiar with those, so I won't really be commenting on any others. Most of them are paid subscriptions. So again, if you're working in an adult ICU without access to one of the more specialised references, I'd recommend discussing that with your drug information service and trying to organise something along those lines. And the other thing to consider is that most of these references actually come from overseas. So their country, so they might use a different nomenclature. So example, noradrenaline versus norepinephrine. Paediatrics. Not in any way familiar with these, but I've been recommended them. In particular, the Paediatric Injectable Guideline from the Royal Children's Melbourne Hospital. This reference includes, in particular, useful information regarding the compatibility with PN formulations and lipid emulsions such as SMOF. So, starting off, Injectables Drug Handbook. It's a great starting reference and is my recommendation as a starting point for the nursing staff as well as ward pharmacists. It's easy enough to use and has enough content to cover a lot of common ICU combinations. The online version is updated regularly, and that's what I recommend we sort of keep here from an infection control perspective, and also because it gets updated regularly. And the 8th edition now contains a number of ICU specific recommendations, which is great. However, its utility is limited a little bit in the higher acuity patients with limited access and multiple infusions needing to run concurrently. But for intermittent intravenous medications and a smaller number of continuous infusions, it's an excellent reference. The King Guide. So the King Guide is my go-to reference for the more complex patients. You can search for up to 10 IV drugs at a time, and it provides this really user-friendly output table. It works well with my brain, being able to picture it like that. A green square, like that one with the C in it, that indicates compatibility. The red is obviously incompatible, hence the big red cross in it. And the orange sort of indicates maybe compatible or conflicting reports. One of my favourite features is that you can click on the individual combination, so you can click on the green C or the red X, and it'll provide you a pretty simple review of the available compatibility data. It also provides some information on in-syringe and admixtures. So it's pretty useful for those areas as well. As well as the sort of the references I'm going to talk about next, it's a bit more detailed. So if you do have access to it in your local health network, I'd sort of recommend keeping it to just for access to pharmacy staff, because the simple, in my experience from it, like when I've printed these tables off, it can sort of enable a bit of overconfidence in the nursing staff and doesn't take into account pharmacological compatibility, which I'll discuss a bit later in the talk. So it can be really useful, but it's just sort of making sure that you know fully what you're doing with it. So Micromedex is another really useful reference that's available. It's powered by the Trissel database, which is historically the gold standard of IV drug compatibility. Much like the King Guide, clicking on the individual drug combinations will give you access to the primary references between the two drugs, and it gives you a nice review of them all individually. I personally use it if I'm unable to work out a workable solution using the King Guide, because it does have a bit more. I feel that I'm not backing this up with anything, I don't know if it's true or not, but it feels like it's got more data in it, but it's not as user-friendly with the table, in my opinion. And as such, I know some of my colleagues prefer it over the King Guide, but I just prefer using the King Guide. So this is the American reference that's just been made freely available by the American Society of Health System Pharmacists. So it's their injectable drug handbook, their yellow book. I've tried using it out a bit recently, but it isn't a reference that I would use over some of the others that I've already mentioned. Just because of its functionality, it's a bit clunky online, and it might just be that I've not used it much before. But that being said, it's free currently. So if you don't have any of the other references that are available and your drug information service are not able to get subscriptions, or there's some delay in it, it's a good starting point because it is freely available if you search for it through the American Society of Health System Pharmacists website. Stabilis is another free reference that's available. I haven't used a lot of it, but I know it's quite useful for manufacturing pharmacists. That being said, when I was playing around with it the other day, I did notice that there's the ability to make a custom compatibility table, which I've sort of tried to do here with this little screenshot. So you can actually make a PDF of the blue and red and grey table on the right-hand side there, which could be really useful if you're dealing with patients of a higher acuity than your normal healthcare facility might be used to, because you can actually print it off, laminate it, stick it around the unit. But one thing I would say to do if you do make one, as I mentioned on the next slide, limit it to just the most commonly used drug. Don't think, great, I can put every single drug that's ever going to be used on here, because otherwise these sort of tables like that can get very complicated quickly. And so moving on to the different types of compatibility charts, there are heaps of ICU drug compatibility charts online. As you can see from the Google search I've done here, just of ICU drug compatibility chart, there's literally thousands. They can get very complicated and difficult to use. I ordered one online a few years ago, and it was a huge sort of A1 sized poster, which limited its practicality pretty heavily. And as such, it's just gathering dust on a shelf in my desk. They're tricky to use, and you need to use a ruler to line up the individual rows and columns, and it's quite easy to sort of misalign the ruler and get the incorrect data. So, I mean, they're good if you can keep them simple and just sort of include your simple commonly used things, but the ones that are available online are typically complex, as you can see in the pictures there. So that's just an overview of the various resources and my personal opinions on them. Don't take them as a gold review. I don't have King Guide shares or anything like that, but that's just my favorite. But it's just a matter of playing around, using the different resources, and find one that suits your needs. Yeah. So what actually leads to IV compatibility, and how can it affect the patient? I'm not going to go deep dive into the science, just being mindful of time, but there's a number of factors that need to be considered when reviewing intravenous compatibility. The data available in the resources I just went through is sort of a set concentration, set diluents, which result in a set pH, and it's done at set temperature conditions and set light conditions. So when you actually look at it, it may have limited practical applicability to the direct patient in the unit and what's being done at your site. So that's something that you do need to consider. In terms of administration, you do need to consider whether the access is peripheral or central, as that can affect a number of things that can affect the stability as well. Some medications can be administered via a central access more concentrated and at faster rates than they would be if it was administered peripherally. Your site may have a local guidance on medication administration or minimum infusion volumes via a central line. If you don't, a quick Google will find you this useful document here, the purple one I've sort of cut and paste in here, from the UK, the minimum infusion volumes for fluid-restricted critically ill patients, which is of some use. And the 8th edition of the Injectable Drug Handbook does have some information regarding sort of central and fluid-restricted patients as well. But it's important to remember that just because something can be given quicker and in a smaller volume via a CVC, that might not be the best solution, particularly electrolytes, where the more rapid administration can enhance elimination. And more concentrated administration may increase the risk of patient harm if inadvertently administered peripherally, which does happen. The potassium, I thought it was a central line, but it was just a peripheral line. But I gave it neat. Oops, the patient's arm is now sore. That happens, that kind of thing happens. So that's why I sort of always recommend diluting it rather than giving it straight neat all the time. I'll touch on propofol at this point. So when assessing IV compatibility with propofol, it's well worth to view a summary of the primary literature, which is available in Micromedex and the King Guide. At the very least. Often studies conclude something along the lines of It is incompatible based upon unable to visualize the precipitation in the line due to the milky lipid appearance of the solution. But despite our laboratory-based findings that there was nil drug loss at 24 hours or something along those lines. So in these settings, it's important to put that into some sort of context of the patient and use that as one of your tools when you're weighing up a risk-benefit assessment. One of the first considerations when faced with compatibility questions should be what is it? Is it continuous? Is it intermittent? The trickier scenarios have multiple continuous infusions, but as you can see from this graph, that makes up only a small proportion of common incompatible combinations in an adult ICU. There is some inherent flexibility in intermittent doses typically. The dose times can be shifted around to facilitate compatibility, and a brief interruption to some continuous infusions can be made to facilitate their administration. So an example of this in my practice is that in some patients, I might recommend an infusion such as insulin, so obviously not when it's only when it's clinically appropriate, such as like a mild stress hyperglycemia in a septic patient, but not like a type 1 diabetic or a DKA patient. So I might recommend that insulin infusion be interrupted for a brief period of time, maybe a minute or two, maybe 20 minutes, half an hour, just to enable the administration of an intermittent medication that's otherwise incompatible. The interruption of the insulin will have a minimal impact on the patient, but could facilitate with the adequate aspiration and flushing the administration of that otherwise incompatible medication. But it's just really important when you do that you check how long the infusion needs to be interrupted for, taking into account that multiple doses throughout the day. So if the medication's QID and you have to stop it for 30 minutes, that's 2 hours interrupted throughout the day, and that may not be always clinically appropriate. So the pharmacological compatibility, this is one of the biggest benefits that as pharmacists we can bring to compatibility advice. So anyone can look at a list of medications and say, I've got drug X and I've got drug B, and this book says that drug X and drug B are okay. I'm not sure what this is officially called, but I just call it pharmacological compatibility. And the what these references don't tell us is, owing to the pharmacological effects of the drugs, should the two drugs be run together. So if we take two drugs relatively commonly used in the ICU, so sodium nitroprusside, a very potent arterial and vasodilator, and propofol, a commonly used sedative agent. If we look at this excerpt from one of the compatibility references, the first response of a doctor or a nurse caring for this sedated patient who might suddenly sit up and pull their endotracheal tube out would be to bolus the propofol. And a bolus of typically 3 to 4 mils will be enough to get that patient resedated and set them back down. However, if the propofol were running through the same lumen as the sodium nitroprusside, depending on how long the tubing to the patient is, a significant dosage, 1 to 2 mil of sodium nitroprusside would also be administered. But the reference says that they're compatible. Now, if that were to occur, and that bolus of sodium nitroprusside were to go to the patient, that would probably lead to the patient dying. So as pharmacists, this combination, even though the textbook says it's compatible, we know the pharmacology of those drugs and we know that they can't run together because of the concept of pharmacological compatibility. So keeping medications that shouldn't be purged and bolused away, such as vasoactives, away from commonly bolused medications such as sedative agents is a really useful thing we can do. So before I wrap it up, I'll give some general tips I give to new pharmacists before they start with me in the ICU. If you're an ICU pharmacist already, you probably have variations upon these in your own practice, but if you're new, this is some tips for you. So there are a number of drugs that just don't go with anything. So if you see a patient on one of these, it's worth your time double checking how everything is being administered. So in my mind, TPN, sodium bicarbonate, high concentrated glucose, calcium salts, magnesium salts, pantoprazole, phosphates, they're all what I would consider or call red flagged drugs. Other red flag drugs are drugs where there's a significant risk of inadvertent boluses, and the best example of this is sodium nitroprusside. So they're just a cue for you to just stop and double check the compatibility if you see one of those drugs on the chart. A lot of the time, drugs with similar therapeutic targets are compatible, which is handy because it also limits the pharmacological compatibility I spoke about earlier. Nursing staff also really like this when you're recommending it to them because it allows them to have a sedation line and a vasoactive line, which simplifies things for them. However, don't take this rule as gospel. It doesn't preclude you from checking individual compatibility, but it can give you a guide. One of the most common phone calls I get from the nurses is, hey Simon, is it okay? It's okay for drug A to go with drug B, right? And my advice is never don't answer that to you guys today is never answer that question directly. Always ask them a few other questions before you give the answer. So the questions are like, what else have they got running? What access do they have? Is it continuous or is it intermittent? Get the full picture before you answer. Not only does it give you a chance to load up your references and make you look really smart because you know over the phone, it looks like you know the answer off the top of your head, but it also ensures that you get all the information you need to appropriately answer that question. Often you'll find that in this, like in this scenario I've said above, where that drug C and drug D might also be running with drug A, but because the nurse has got drug A in their mind, they're only thinking of drug A. Another good question when dealing with intermittent medications is, can it wait, particularly with electrolytes? ICU nursing staff typically want to give all their medications in as small a volume as possible and as quick as possible, because then it gets it done for them because they're busy with other things. But if there are a couple of stat orders for some top-up electrolytes that have been charted, chances are these can run sequentially, thus potentially answering the question that you've been wrong about. I want to give my potassium and I want to give my magnesium. I can put them together, right? Well, the answer might be, well, no, give your potassium. When that's done, give your magnesium then. As I touched on at the start, the majority of combinations have little or conflicting data regarding their compatibility. The first advice is don't panic. There's usually a simple workaround. My best advice I can give here is to think practically. Can an infusion be held for a short period? Is there an equally effective other route suitable for the patient, like enteral or subcut or IM? Does the patient have any peripheral access? This is always overlooked in the ICU. Or if they don't have it, could it be inserted? Rather than a continuous infusion, could the drug be given intermittently? This is a really good opportunity to look at deprescribing, as you may find that insulin infusion running at 0.5 unit per hour could actually be ceased, or maybe that antibiotic, broad spectrum antibiotic, could be de-escalated to an enteral one. Failing all of that, what you need to think about is the risk versus benefit of that combination. Like all recommendations, an ICU pharmacist makes a careful assessment before taking place. If there's no data to say that combination is incompatible, are you willing to accept the risk depending on the importance of that medication to be administered? If it were incompatible, would there be a case report documenting patient harm? Maybe, maybe not though. People are less likely to report instances of two medications running together, so maybe there would be. But don't be afraid to say, I can't give you an answer. But make sure that you combine that with my last tip and put in place adequate safeguards such as regular line inspections from the nursing staff. One of the best resources that we have are our nursing staff. Patients with a higher acuity typically have higher number of infusions running and more complex infusion regimes. But thankfully, the nurses who care for these patients will be the more experienced nursing staff, and they will have in their mind what infusions they like to run with other infusions. They've been doing it for 20, 30, 40 years. So in these instances, when I'm reviewing a patient or I'm asked to review, I'll open with the line, well, what have you got running already? And my first step is to review the arrangement they've already set up. And in my experience, that arrangement is typically suitable. And they're just after a bit of peace of mind, typically because they've got other things on their mind. They've got a busy patient. If you can't get a solution, just make sure the nurse who is looking after the patient knows that, and that they're mindful of keeping a close eye on the lumens and precipitation forming in the line. So just putting all of that junk together, the biggest thing I can say is there's no single correct answer, which is hard for us pharmacists to accept it sometimes. Because we like to have yep, this is the answer. But unfortunately, there's lots of answers in this area. And usually there's a bit of a spectrum on right and wrong, but, you know, just see how you go. So this theoretical, hypothetical CTSU or cardiothoracic patient returns from the theatre with a 3-lumen CVC. He's sedated with propofol and has noradrenaline running. He has an order for sodium nitroprusside just in case he becomes hypertensive. He's also charted for intermittent pantoprazole for stress ulcer prophylaxis and prophylactic cefazolin and PRN IV fentanyl. Now, this is just my mindsets, so you may have different ways that you would do it, but this is how I would do it. So in this setting, I'd be aiming to have 2 continuous lumens and 1 intermittent lumen. It's always easier if you can to give your intermittent medications their own spot, be it peripheral or a central lumen. It doesn't matter if they aren't compatible. You just separate out their administration times and make sure the nurses know to flush the lumen well prior to and following administration. Due to their pharmacological incompatibility, I would favour propofol running by itself through 1 lumen and then the noradrenaline running through the other. Should the patient become hypertensive, the noradrenaline would have stopped and that lumen could be flushed and aspirated and used for the sodium nitroprusside. Moving on, this hypothetical patient has progressed to a low cardiac output state, complicated by post-op AF. There are now more continuous infusions than there are lumens. Oh no, what are we going to do? But a quick consult of my references reassures me that I can combine the noradrenaline and milrinone. I'm not going to be bolusing either of these, so they can run together in this setting. I can then run my propofol separately and my insulin by itself also. When I need to give the pantoprazole, ceftriaxone or fentanyl, I can interrupt the insulin for the required period of time and restart it, as the patient isn't a type 1 diabetic, nor do they have some other high clinical indication for insulin. In that instance, a brief interruption is an acceptable risk for this patient. Let's rejoin this patient a week or so later, and they've had a turbulent time, sustaining a significant hypoxic liver injury following a post-op cardiac arrest. My first step in this patient would be bring up to one of the tables I can produce in the King Guide, but that's just what I would do. Others may prefer another method. I want to start with the tricky bit, the N-acetylcysteine, which has no compatibility data, which is a shame. I would generally run it at a consistent rate, and it wouldn't be bolus, so it would be ideal to run with other infusions. But given its lack of compatibility, let's give it its own lumen. Depending on the reference I look at, I can see propofol, fentanyl, and midazolam are potentially compatible, although it isn't ideal to combine 3 infusions with only single individual compatibility data. Given the acuity of the patients in this setting and the other potential options, this is a potential solution, and one that in this patient I would probably end up choosing. I have a single lumen left and a few options. In this instance, I would tend to go for my amiodarone and noradrenaline, as I want to keep them both administered centrally and not peripherally. Looking at the King Guide, it tells me that this combination has conflicting data. So I consult Micromedex, and that implies that there's actually quite good compatibility data between the two. And as such, I'll be recommending to run these two together. Again, it's not an ideal situation as the information is conflicting. So it is a risk-benefit assessment in this situation. So that leaves me with my heparin, insulin, pantoprazole, cefepime. My thought process would be that these can all go peripherally, provided peripheral access can be obtained. Insulin and heparin could briefly be interrupted to administer the pantoprazole and cefepime. Additional consideration could be given to switching to an enteral anticoagulant and an enteral PPI if clinically appropriate. Changing to subcut insulin, and depending on the patient, this might be a good opportunity to consider de-escalation of cefepime to another agent. As I have already stated, there is no single correct answer, and what I have just explained is my thought process as I wrote this slide out. In a different patient with the same infusions, another solution might be required, as peripheral access might not be able to be obtained, or perhaps the risk of running medications with questionable compatibility data together isn't outweighed by the benefit. It's not exact, but keeping your options open and thinking practically can usually lead you to a recommendation. So COVID-19 has added some complicating factors to drug administration, and although thankfully so far we've been lucky to avoid a lot of these problems in Australia for now, and hopefully we'll avoid them altogether, it's worth mentioning these COVID-specific problems that other countries are facing in preparation to should we face them in the future. So when consumables such as syringes and pumps are running low, utilising combination syringes is a viable option. Although it shouldn't be considered by any means a standard practice, and alternative options such as stopping other infusions, utilising alternative dosing regimes and other routes should be ruled out first. There are 2 aspects to consider when combining medications in a syringe for infusion. Firstly, physical compatibility. A good reference such as King Guide or Micromedex should be consulted, and combinations with known compatibility should only be used. A common diluent should be used for each medication, so you shouldn't be diluting one with water for injection and the other with saline. You should be diluting them both with water for injection where possible. And a test syringe with regular checks for physical incompatibility should be compounded by one of the nurses or yourself prior to administration, and acids and bases should not routinely be mixed. Secondly, the pharmacological compatibility. Only medications with similar rates should be combined. There is an obvious danger in combining a medication which requires an infusion rate at 10 ml per hour and an infusion rate at 1 ml per hour. Also, medications with similar mechanisms of actions should only be combined in a syringe. You shouldn't put a neuromuscular blocker in one of these combination syringes, for example. Should this be the path that you wish to investigate for your healthcare network, I would suggest reading the Specialist Pharmacy Service from the UK guidelines in mixing critical care injections together in a syringe during COVID-19. They're freely available via Google, and they have some drug-specific references on that website as well. They've got some monographs there. One of the other problems faced in the epicenters of COVID pandemic has been a shortage of infusion pumps, and that's been brought about by higher higher acuity, so more pumps needed for each patient, and a higher number of patients as well. So should you be faced with shortages of drug pumps, pumps should be prioritised to high-risk drugs in high-risk areas. That means there shouldn't be a smart pump administering fluids on a surgical ward, and that smart pump should be in the ICU administering noradrenaline. Additionally, in preparation for any upcoming shortages, cataloguing of hospital-wide pump availability should be undertaken, be it by yourself or someone else in your department or somewhere else in your healthcare network. And this should include pumps in non-clinical areas such as biomedical departments. We've got a stack there for some reason. Training in sim rooms and other low-risk areas such as radiography and outpatient clinics. You don't want them hidden away in the basement when you don't have any in the ICU. As a last resort, gravity and drip medication administration is also an option, and the UK Specialist Pharmacy Service recommend that any medication where the rate of administration does not need to be tightly controlled to prevent an adverse effect can be administered by gravity infusion. And there's some guidance as to what these medications include, as well as linking to a page that provides a drip rate calculator. And that again is on the UK Specialist Pharmacy Service website. And if you're interested in pump conservation and some of the other sort of creative things that they're having to do in the US currently with their pumps, there's a free webinar that the ISMP or and the ECRI organisation did about pumps on 8th of April, and it's freely available on both of their websites, and it was quite an interesting watch. And that's it. Happy to take any questions. Alana's still sitting here if you've got any questions for her as well.
Many thanks, Simon and Alana, for the comprehensive overview. We are just past 2 o'clock. We've had a question come in during the webinar from Joanna. Just wondering if there are any concerns with concentration of drugs via central lines. For example, vancomycin infusion is available in 20 milligrams per mil, but the AIDH has info on it only up to 10 milligrams per mil.
Cool. All right. So yeah, I'm happy to field that one. So that probably comes back to just that's the available data. That if you look at the actual primary literature on it, the compatibility study was probably done at a set concentration. So it's it comes back to that risk benefit. Are you happy to look at changing that compatibility, changing that concentration from what's set there and running it with other things, or are you if your local policies dictate other concentrations, are you happy to exclude a line entirely for the vancomycin infusion that you're running concentrated otherwise? And so for me, depending on the patient, I'll look at the compatibility, but it's one of those things that, well, on a risk benefit, if I've got 20 infusions or 15 infusions and I'm struggling to get a combination, concentration might be one of the things that I look at and go, oh, well, it was compatible at that concentration. I'm not quite at that concentration, but I'm happy that on the face of it, it helps me, give me an option. Otherwise, this patient wouldn't be able to have all of these infusions because there would be, frankly, no data for them. Hope that helps.
Thanks, Simon.